Welcome to this explainer. We usually think of our eyes just as tools for seeing the world, right? But actually, they're this striking, color-coded diagnostic window straight into the health of the entire human body. By decoding the exact visual footprints left behind in the eye's tiny vessels, we can uncover massive, systemic pathologies happening literally everywhere else. It's like being a medical detective. Here's what we're looking at today. We'll start with fluid dynamics and color changes, move into the architecture of ocular bleeding, then look at Virchow's triad and retinal clots, visualize some intravascular emboli, and finally wrap up with ischemia and systemic shock. Let's get into it. Section 1. Fluid dynamics and color changes, the red and blue canvas. So when fluid dynamics change, the visual contrast is absolutely stark. Think about active hyperemia. This is an active process where arteriolar dilation leads to increased blood flow, usually driven by histamine during something like an allergic reaction or uveitis. How does it look? Well, it physically manifests as this bright red ciliary flush. It's basically screaming active inflammation at you. But on the flip side, passive congestion gives us a totally different color palette. Here, impaired venous outflow causes all this stagnant, deoxygenated blood to just build up and sit there. You'll see a dark red or even bluish vascular distension, and that's a direct visual mirror for blockages, things like a carotid cavernous fistula or elevated episcleral venous pressure from glaucoma. The color alone is literally telling you the story of active flow versus a passive blockage. Now, what happens when vascular barriers break down or when Starling forces, that delicate pressure balance keeping fluid where it belongs, get thrown off? Fluid accumulates, right? And it physically thickens the tissues. We can classify this just by looking at the pictorial representation. If we're talking exudative edema, it's inflammatory. The endothelial permeability ramps up and protein-rich fluid leaks right into the tissue, just like we'd see in posterior uveitis. But if it's transidative, it's non-inflammatory. That's just a straightforward hydrostatic imbalance. If we zoom in on specific structures, say corneal edema from an endothelial pump dysfunction, it actually shows up as cloudy stromal thickening along with blisters we call bullae. Meanwhile, macular edema kicks in when blood-retinal barriers break down, and that allows fluid to pool directly into the Henle layer. Moving on to Section 2, the architecture of ocular bleeding, shapes with meaning. A hemorrhage in the eye is kind of like a microcrime scene. The physical shape of the blood tells you exactly what layer of the anatomy is failing. For instance, a flame-shaped bleed visually proves that blood is trapped up in the superficial nerve fiber layer. Since it tracks right along those linear nerve patterns, it fans out like a flame. It's a classic, textbook visual marker of systemic hypertension. Contrast that with dot and blot hemorrhages. Those happen deeper down in the retina in the internuclear or outer plexiform layers. Because that blood is vertically constrained by tightly packed cells, it forms these distinct round dots and blots, which instantly points us toward diabetic retinopathy. And then we have subhyaloid hemorrhages, which form this very distinct boat-shaped collection of blood, pooling right between the retina and the vitreous. It's all about the physical boundaries forcing the blood into these highly specific diagnostic shapes. Section 3. Virchow's triad and retinal clots, the anatomy of a blockage. As we know, every in vivo blood clot is driven by Virchow's triad. It's this incredibly delicate mathematical balance of three factors: endothelial injury to the vessel wall, hypercoagulability, which is just a fancy way of saying sticky blood, and stasis, or slow flow. When these three elements align, they set off a cascade that turns into sheer visual chaos inside the eye. And that brings us to one of the most dramatic visual diagnoses in all of medicine. If a thrombus forms right at or just behind the lamina cribrosa, it blocks the central retinal vein. The resulting central retinal vein occlusion is so catastrophic it actually earned the clinical name blood and thunder fundus. The eye is literally painted with this explosive, widespread intraretinal bleeding simply because the blood has nowhere to drain. It's quite a sight. But imagine the exact opposite happening. If an atheromatous plaque cuts off the central retinal artery, you don't get explosive bleeding. Instead, primary macular perfusion is totally shut down, and the retina simply starves. It dies off, turning into this ghostly, opaque ground glass white. And against that stark white background of dead tissue, the macula shines through from an intact underlying choroid blood supply. It appears as this grim, cherry red spot. It's absolutely an unforgettable warning sign. All right, Section 4, visualizing intravascular emboli, color-coded danger. So traveling masses, or emboli, actually act as a highly specific, color-coded diagnostic guide. If you're looking and you spot a bright yellow speck wedged at a retinal vessel bifurcation, you're looking at a Hollenhorst plaque. That bright yellow hue, it's the exact physical manifestation of cholesterol, telling you straight up that it originated from the carotid arteries. On the other hand, if you see a dull, dense white rock, that's a calcific embolus. That points directly to a dangerous cardiac valve defect, which, by the way, carries a much higher risk of complete artery occlusion. And finally, those dull gray-white plugs are platelet fibrin emboli. These are usually the culprits behind transient monocular visual loss, that fleeting blindness we call amaurosis fugax. And finally, Section 5, Ischemia and Systemic Shock, when the system fails. We have to understand that sudden ischemia leaves very distinct physical scars on the ocular landscape. You might see what we call cotton wool spots, and they look exactly like they sound. Little fluffy white patches sitting on the retina. But they're actually microinfarcts where their nerve's transport system, the axoplasmic flow, has been totally interrupted because of a blocked arteriole. Another major marker is anterior ischemic optic neuropathy. This is a full-on infarction of the anterior optic nerve head, which is supplied by the posterior ciliary arteries. The result? Sudden, painless, but absolutely devastating vision loss. Now, if we zoom out from local blockages to total systemic hypoperfusion, we hit the clinical math of shock. Whether it's hypovolemic or cardiogenic, shock causes a massive drop in your mean arterial pressure. And that is absolutely crucial because of this stark mathematical truth. Ocular perfusion pressure is directly tied to it. It literally equals 2/3 of your mean arterial pressure minus your intraocular pressure. This formula forces us to ask a pretty terrifying diagnostic question when evaluating a patient in systemic shock. If their arterial pressure plummets, their ocular perfusion pressure crashes right along with it. So, what exactly happens to the visual landscape of the eye when it can no longer sustain the tissue? Well, the answer is severe tissue hypoxia, which triggers a complete visual whitewash. Clinically, you'll see stark, bilateral retinal ischemic whitening, along with glaucomatous field loss progression, even if the intraocular pressure itself is totally normal. The eye literally drains of its healthy color. It's the body signaling catastrophic hypoperfusion and, frankly, an immediate severe threat to the patient's life. We'll leave you with this final thought. The next time you think of the eye, remember that its complex web of vessels is doing so much more than just capturing light. By understanding how to read a simple flame hemorrhage, a bright yellow cholesterol plaque, or a blood and thunder fundus, you gain a real-time visual map of systemic health. We hope this explainer helps you see the incredible diagnostic power of ocular hemodynamics. It kind of makes you wonder, the next time you look in the mirror, what invisible, systemic secrets might your own eyes be trying to reveal?